Thank you very much, Ruth. So the meeting organizers and Dr. Veith assigned me not one but two talks on compression today. So I'm going to focus on deep venous disease now, and we'll talk about superficial vein compression later. No related disclosures. So we all know the purposes of compression to support the calf muscle pump, reverse venous hypertension, and reduce symptoms. But I think I want you to focus on the fact that many patients, particularly with ulceration, develop very high ambulatory venous pressures. And the question is really, what are the limitations in compression at treating these patients? And that's what we'll focus on. So there's a large body of literature, which we can't go into now, including studies from revered authors such as Professor Nicolaides, on the effects of elastic compression, and this is when we used to measure pressures in patients by jabbing needles in their feet and having them walk around, and showing that venous hemodynamics improve under compression. What does it do with the healing of venous ulcers? This is a study done by one of our plastic surgery residents, Stephanie Biedler, where she treated patients with compression for 4 weeks who had venous ulcers and measured anti-inflammatory cytokines and MMPs, and showed that they reduced significantly during this 4-week compression period, and this correlated with healing. Both MMPs as well as interleukins and TNF-alpha showed this same pattern. So there's a real metabolic effect of good compression that correlates with wound healing. So if you look at the Cochrane Review and looking at all of the literature, it seems pretty clear that using compression versus no compression for a patient with an ulcer results in better healing more quickly and with reduced pain and better quality of life. So I don't think this is really an arguable point. But the question is, does this benefit everybody? So this is data from our clinic, and if the wounds are pretty small, they heal quickly. But if you look at the line on the right, that's patients with wounds greater than 20 square centimeters. And I'll submit to you that a 50% healing rate at 6 months is really pretty awful in treating these patients. They really don't have much of a life while they have an active ulcer. So compression by itself is not really going to get us where we want to be for a significant number of patients. Clearly, the EVRA trial and others have shown that adding other therapies to compression alone is beneficial for patients. This is with primarily superficial disease, and I think our limitations really come into a lack of understanding in many of the wound clinics that treat these patients that the type of venous disease matters. So there are hundreds of wound clinics out there that never measure venous anatomy or function and treat patients with compression-based protocols, and many patients don't heal with this. I think that I'll submit to you that patients with deep venous reflux and even worse, obstruction, don't do very well with compression-based protocols. This is a study we published back in 2002, and we looked at patients with class 5 disease after ulcer healing to see if they had recurrence. And we found that there was a significantly higher incidence of recurrence using compression if they had deep venous reflux or a higher venous filling index. So you can see that over half of patients had recurred at 3 years if they had deep venous insufficiency, compared to about half that if they did not. And then finally, looking at patients who have venous outflow obstruction, we looked at over 60 patients who had venous leg ulcers and this type of anatomy. We were able to clear the outflow path in 48 of those patients, but could not or were not able to try in 14. And if you look at their outcomes, it's remarkable how different they are. About 80% healed if we were able to open the outflow versus only a quarter if they had a continued obstructive venous outflow tract. So I think the key is that compression clearly is useful. It's a basic form of therapy that we use in all patients, but you have to assess how your patients are doing with this. And if they're not making marked improvement in 4 to 6 weeks' time, we should move to doing other therapies wherever possible. Thank you very much.